Hello, everyone. Welcome to this webinar organized by Incepto, which is an AI-based platform for medical imaging. We are going to focus on AI for aortic aneurysm monitoring and follow-up. And it's my pleasure to run this webinar with huge experts in the field, key opinion leaders. We have Tara Mastracci, Dominique Fabre, and Arshid Azarine. Tara, can you introduce yourself, please? Thank you, Tara. Arshid?
Hi, thank you, Stéphan. I'm Arshid Azarine. I'm head of Cardiovascular Imaging Department in Groupe Hospitalier Paris Saint-Joseph in Paris, which is divided in two hospitals, Saint-Joseph and Lannelongue, where Dominique and Stéphan works more. And I'm keen on everything cardiovascular, CT scan, and MR, and working on the subjects.
Thank you so much, Arshid. And my partner, everyday partner, Dominique, can you introduce yourself?
Thank you, Stéphan. So I'm Dominique Fabre. I'm a cardiovascular surgeon working in Lannelongue Hospital, and I am at the initiation of the development of the EVAR program with Stéphan.
Great. So thanks again. It's great to have experts and friends connected on this topic. And the idea was to build a webinar around our everyday practice and everyday need, and especially focus on unmet needs. And so we will start by the radiologist perspective. So Arshid will talk about how he evaluates aortic disease on his everyday practice. Then we will move to Tara and have the surgeon's perspective. So Arshid, the floor is yours, and we look forward to looking at the slides.
Thank you. I guess we will see the slides appearing right now. Oh, thank you. So I will say the problems we have as radiologists, actually, to when we are doing the evaluation and measurements of the aorta, which we do most of the time when we have aneurysmal disease or polyaneurysmal diseases like Marfan disease, for the follow-up of type B dissection or type A with thoracoabdominal dissection, pre and post therapeutic. And we have right now a lot of tools with computed fluid mechanics, with the 4D flow, wall shear stress, and volume 3D measurements. A lot of new tools, very advanced, but in clinical practice, this is the maximum diameter, which remains the only argument for intervention and for the follow-up of these patients. Which is correlated actually with the risk of aortic dissection of rupture, as you know, with the Laplace law. But it's not always as easy to do this measurement. Actually, as you know, aorta is curved, and the aortic length and tortuosity increase with age, and it becomes more and more tortuous and length. So it is very easy when you use only the transverse images, native images, to do bad measurements, and you maximize or you overestimate the real size of the aorta. So to do a cross-sectional measurement like here with double oblique multiplanar mode is very important. But when you have an aorta with multiple lesions, multiple dilated areas and regions, well, it is very time consuming. So we have two issues. One is that many times we don't have the right measurement done, and it is very often then that people call me because this measurement has been done by someone not specialized, and I have to check it again for the relevancy of the measurement. And the other thing is that for the follow-up of some difficult patients, it is very time-consuming to do all these measurements. This concerns thoracic aorta, but also the abdominal aorta, with many discrepancies which can be seen with non-expert observers. As I was telling you, we do it in this polyaneurysmal and dissection cases with, as you can see here, many measurements everywhere. We have this dilation and for all the segments of the aorta. So this is important, very relevant, but time consuming when you want to do it really optimally. And sometimes we have also incidental findings. I mean, you're following up somewhere and you have a dilation or aneurysm appearing somewhere else. And if we don't pay attention to these other parts ourselves, we can miss aneurysm, which can become dangerous later. So there is a need really for an automatic detection. Reliable automatic detection and measurement of the maximal external diameter of the aorta in its different segments. And if we can use artificial intelligence, that would be great. So I maybe let Stéphan go to the next talk.
Well, thank you very much, Arshid. We have some time for a discussion. And I would like to advise everyone that you can actually ask questions on the chat. It's a unique opportunity to ask expert radiologists or surgeons questions. We will move slowly towards the AI solution. But starting from our current practice, Arshid, currently when you evaluate an aorta from the root to the aortic bifurcation, what type of sizing tool do you use? Do you have a 3D workstation? Do you rather recommend MPR reconstructions or a center line and a stretched view of the aorta? What is your current practice?
Well, you have the safe mode, which is this multiplanar double oblique thing, which works with all the softwares and all the time, but which is quite really time consuming. Now we have some, most of the constructors have this vessel analysis tools, which help you to make a curved image of the aorta, and which is very helpful, but it's not optimal, because the center line is always is never traced optimally. So you have always to check the center line and to correct the center line, otherwise you're doing again false measurements. So these tools are very helpful, because you see at one glance where is the most dilated, which is where is the area to measure. But you have to be very careful and correct this center line, which again takes a little bit of time when you have different measurements to make. But these tools really help, but it's not automatic. It's just a help.
Before asking Tara how she does it in her everyday practice, I just want to challenge you, Arshid, because those semi-automated center lines, usually they are made from the luminal aorta, the contrast-enhanced part of the aorta, and which is not really the aneurysm. So it's another reason why sometimes those measures are not accurate. Would you agree with that?
Of course. Actually, I use the center line and this tool to have an image of the lumen, but then you see where the size is the maximal. I mean, the most dilated, and then you do it by hand. Actually, you do it manually. It is true that in all these softwares, everything is done to have a measurements of the lumen and not of the thrombus around the aneurysm or other things. Maybe the dissection, the false lumen, the everything around, everything in the aortic wall is not included, of course. That helps to do it finally manually, the measurement.
I have also one question, Arshid. Is there any definition from your society about the measurement of the inner or outer diameter of the aorta?
Of course, everybody knows that you have to do it. You have to include the wall, and now it is also the same for the thoracic and ascending aorta, which was not the case before. For the abdominal aorta, everybody knew that you have to include the wall. For the ascending aorta, that wasn't that clear actually, but now it is in the definition.
I think those early screening studies in the United Kingdom are the ones that didn't include the wall. So we're slowly growing over that.
Yeah.
And Tara, in your everyday practice, how time-consuming is it, and how do you evaluate the aorta? If let's say a patient comes to clinic prior to any kind of repair.
Well, I echo what Arshid said. I think that the proprietary systems that come with PACS software, like CareStream is what we have, they have the ability to do a vessel analysis, but in fact, it's very difficult to adjust the center line, and you just don't get a good sense that you're getting reproducible measurements. So you end up spending a lot of time in MPR. And that is just, it takes time. So to prep for my clinics, I usually do all the imaging analysis first because there just isn't enough time to do it in real time. I think programs like Terra Recon have helped a bit because it's a bit more automated, and certainly SIDAR Medical is building a post-processing software that also can measure. But none of these things are kind of fit for purpose just yet. They do take quite a bit of labor.
So Tara, do I understand correctly that you work on the images prior to seeing your patients?
Yes, I do.
Okay, so a consult for you and a 1 hour consult is a 2 hour part of the day.
Yeah, having imaging that would be available immediately would be a game changer in terms of being able to see patients more efficiently.
Fabulous. Let's move to your talk, Tara, and I'll have Dominique question you on what you're going to present. Not challenge you, but come up with a couple of comments because he has a huge expertise also in aortic aneurysm surgery, open and endo. Go ahead, Tara.
Thank you. The little talk I've prepared is really just a bit to be provocative about where we've been as vascular surgeons. And importantly, these are my disclosures. I think we all agree that long-term observation of EVAR outcomes suggests that there are very predictable modes of failure, and those modes of failure are highly dependent on anatomy. And if you look at major series coming out of databases like this one, the Medicare beneficiary databases, we have hundreds and thousands of patients' clinical outcomes, and we just don't have the imaging to be able to back up or to give us the information that we need in order to predict outcomes. And I did a quick poll, and if you look in the last 20 years, there have been 19 clinical practice guidelines that recommend diameter measurement and imaging analysis as part of the regular practice for aneurysm repair, and yet we don't routinely collect these things in a systematic way. We went back and looked at our practice at the center that I used to work at, and just looked very briefly at a couple infrarenal aneurysms where we actually knew that we had all the imaging that we wanted, and we took it in two eras, a very early era and a late era. And we wanted to focus on imaging alone. And this was incredibly labor intensive. It took us a year, 3 vascular surgeons reviewing all the images to make sure that we really paid close attention to anatomic variables using a severity grading system. And we did things like measure the neck and then measure how much intended and actual coverage we got. Key anatomic parameters that I'm sure our patients think that we look at every day, but actually take a really long time to find. And what we found is between those 2 cohorts, our operative strategy changed completely because we really actually do have a very different understanding of anatomy now compared with a decade and a half ago. And this operative strategy changed despite the fact that there was really no difference in demographics or anything between the patients. And it changed mostly because the anatomic suitability was different. Despite the fact that we stayed on IFU in both eras, we seem to have a better type of outcome and more anatomic severity in the early cohort, and that was true for the distal and the proximal landing zones, the amount of tortuosity, things that are really hard to pick up quickly. And even the aneurysm diameter did have an impact on outcome over time. And, you know, I think it's important to recognize that we saw an increased number of complications in that early group of patients, despite the fact that the technical skill didn't change. We still managed to achieve the same percentage seal length of available sealing zone in each cohort of patients. But it was just in the later cohort, we gave ourselves a bigger sealing zone because we really understood and were able to critically appraise the anatomy in a better way. And I think that has a knock-on effect for complications and reinterventions, and certainly had a huge impact on survival. So what I've learned from this, just looking at our data and looking at typically from an imaging point of view, is that you actually can predict the path that an aneurysm will take if you pay very close attention to the ratio of the post-op diameter and the pre-op diameter at any point during their follow-up. And this, of course, can be plotted and can help you follow up. But this is really, really labor intensive and time consuming. And it kind of does require a more automated solution for diameter measurement in clinics so that we can make these kind of decisions in real time. So my final closing statement is really that I just think high quality imaging data needs to be linked to clinical data in order to improve outcomes. And we've done a pretty good job collecting clinical data over the years, but I think the time is ripe for some good imaging collection.
Fabulous. Thank you very much, Tara. And if I understand well, one of your take-home message is that a diameter evolution is critical. So by monitoring diameter accurately, you can actually realize if a patient is going in the right direction or not.
Absolutely.
That's great. Dominique, any comment?
Yes, indeed. Even this morning, I was still trying to check the evolution of the diameter of the ascending aorta of the patient for the follow-up of this patient to check exactly if I have to do the next CT in 1 or 2 years. And indeed, the diameter is quite stable. You want to do your next CT scan in 2 or 3 years and not in 1 year. And I think it's really something we can decide using this ARVA program. And I was quite a little bit lost this morning because the result of the ARVA was not available. So indeed.
And Tara, let me ask you something. We were trained by the same mentor, Roy Greenberg, and he told us to look at the aorta as a single organ, because whatever you're going to do might fail in the future if a proximal sealing zone at one point becomes an aneurysmal disease at another point. So my comment or question here is, do you believe that it is important at each follow-up to measure every different segment of the aorta?
Absolutely. I think measuring the diameter is important, and of the treated segment obviously is important to see if your treatment worked. But whether or not the rest of the aorta evolves into a more diseased segment or puts your repair at risk, I think is incredibly important. And, you know, when you're in a busy clinic, those are the kinds of things that you don't have time to dedicate systematic measurements to. So I'd say 100% yes, you have to measure the diameter across all segments of the aorta.
And now let me challenge Arshid. Arshid, you are the radiologist here. So are you guys looking at every single segment of the aorta when looking at an aortic CT scan?
Of course. Well, when you're, I would say when you're sensitive to this problem, and when you are specialized in this field, of course, this is what we do. And it's often that when you are following up an ascending aorta, we look at the abdominal too, or the opposite. Sometimes because you have evolution in different parts. But also, I would say that which would be also interesting in the follow-up of your patients with TEVAR for the abdominal aorta, it would be to see as we do it right now with ARVA, the evolution of the maximal diameter, but also where it is exactly, because as you know, this anatomy may change during years, and so that would be maybe hopefully a next step to look at it. But as you said, that this is a single organ, maybe this aorta, and the maximal diameter may really may decrease in one point and increase in the other.
And I think one of the issues is that when you perform the CT scan and when you make your measurements, is you don't always have the CT scans that have been performed months or years before. And so even if you do a very accurate measurement, you don't have the information to provide the surgeon or the interventional radiologist or the cardiologist that has asked for the CT scan. And I think that's one of the main issue.
It is one of the main issues. So this is quite important to have most of the follow-ups in the same center. Actually, this is really comfortable actually when you have patients with all the exams in the same center. So you can really see, and you can go back sometimes to 7 years before and just check how it changed.
Tara, we have a question. Thank you to Maria Elena Leno, asking you, have you already tried to compare an AI tool versus human measurements in order to see if by using the AI tool, your outcomes improve?
So that's an interesting question. I did some research a couple years ago, actually, looking at implementing AI in the post-operative imaging analysis. But rather than look at aortic diameter, I picked something that was slightly easy to measure, which was the size of the kidneys. And we were able to use kind of a fusion type tool to see if the size of the kidneys could predict renal stent failure, and it did. So I think these kind of augmented human tool sets that give us the ability to direct the computer to look at the things we want and then help us measure them are going to be incredibly important. Like, I do think that is the future of aortic imaging, and just so many different iterations that you can play with.
And let me echo Maria's comment, asking you, do you think that actually those AI tools would be better than the current imaging analysis that we have through core labs for all our registries and studies? So in other words, do you think that we should use AI tool to follow up in our everyday practice, but also for all the research going on?
Well, there's a couple reasons why I think yes. The first one is because it'll be more standardized, so human error will be gone. Now, of course, there's going to be need for a lot of validation, and we could talk about when we decide that the technology is ready for prime time. But the other reason is because there's a diminishing amount of research funding out there. And if we can decrease the cost of core lab assessments by doing something in a more automated way, it means that we can offer better and more experimental treatments to patients. So we'll be able to actually expand our research portfolio. So I am 100% in favor of that.
Dominique, you said that this morning you were seeing a patient in consultation. And that you are using the AI solution in your everyday practice. Do you trust the system for your follow-up after endograft?
I think it's a very important point. We have to always check at every segment the measurement of the program and check really in comparing the imaging of the CT scan that is presented by the EVAR report, and check exactly if the measurement is accurate, really accurate. You have also to see at each segment if really the measurement is okay. And I think it's a part of the radiologist. Maybe Arshid could add his point of view, but I think it's really important not to decide only with the EVAR report.
Maybe what we can do, Arshid, if you want, let me show a couple of slides on the EVAR solution and how altogether we evaluated it. And then during the slide show, I will challenge you on all that.
Okay.
So the EVAR solution, the AI solution we're talking about today is EVAR for Augmented Radiology for Vascular Aneurysm. It is a project that we started, Dominique and myself, with the Incepto team a couple of years ago. And next slide. I just have to disclose that we don't have a personal conflict of interest with Incepto, but our group has a financial collaboration with Incepto. Next. So this is how we made this project happen. We looked at our database of over 3,500 CT scans, including healthy aortas, diseased aorta, and stented aortas, with both, including EVAR, TVAR, and also a more complex branch and fenestrated endograft. Next. And the pipeline was designed this way. First, obviously, we had to have the CT scan, and so we have we extracted them from our database. Then the pipeline started by doing an aortic localization, then a segmentation, and I want to really be crystal clear here. The segmentation is not the luminal part of the aorta; it's the entire aorta, outer wall to outer wall. So it doesn't depend on the contrast and hence part of the aorta. It's a complete aorta. If it's an aneurysm, it will include the thrombus and go all the way to the outer wall. Extract it, and then we will have a center line of this aortic segmentation. And then the first step, and this is the paper I'm going to show you next, was to depict the maximum aortic diameter, and this is from the root to the iliac. So it was a paper that we published a couple of months ago, including most of us here on the webinar. And if you can go to the next slide, you will see, and this is one way to answer to Maya Elena Leno's question, how we compared our measurements to the AI system. So what you can see here is that aortic surgeons, radiologists, and residents were involved in that project. And we looked at a significant number of CT scans, and we compared our measures to the AI system. And you can see that between us, amongst surgeons and radiologists with various expertise, the median error ranged from 1 to 2 millimeter, and that the ARVA system was in the lower range of that median error at 1.2. And for those of you who are familiar with AI evaluation, the perfect measurement would be a DICE measure of 1, and you can see that with the diseased aorta and stented aortas, we were not far from reaching 1. Next. So this was the first step. Again, this study was just to depict the maximum aorta diameter of the aorta from the root to the iliac. And the next steps that are ongoing, some of them are already available, was to segment the aorta and to have a diameter measurement for each segment. And then the future step is to have a volume measurement for segment. All this obviously being automatic. Next. And so the pipeline that I already showed you evolved to a next step, which was to perform the segmentation of the aorta in 7 different segments, and then to perform a maximum diameter at each level of the aorta. Next. And you can see here the various segments starting at the root with the ascending aorta, then the arch, descending aorta, and then suprarenal, infrarenal, and both iliacs. Next. And you can see that the segmentation was very, very accurate. The dice measure you can see here range from 0.93 to 9.4, and that was even in patient with dissected aortas, even with patient with stented aortas. So the segmentation is very accurate with the algorithm. Next. And so we are now, this is the paper we're going to soon submit for publication. We are performing the same study as previously, but rather than having a single measurement throughout the aorta, we have a measurement for each segment of the aorta, and again comparing the ARVA system that you can see here in blue to various physicians. This is an example in the descending aorta for following an endograft position in a chronic dissection. Next. Next, please, Eva. Infrarenal aorta here, also in a patient that had a prior EVAR repair. And you can see, again, a variation between the various physician and ARVA that is less than 2 millimeter, which, as Arshid said previously, is in the range of the intra-observator variability. And then the future is the aortic volume. We don't know yet because this has not been evaluated, because in routine practice it's so time-consuming to evaluate the volume of our patient. But maybe if ARVA can come up with automatic volume measurement, maybe this will be the best way to follow up our patient, and maybe Tara will need to perform a lot of new studies with this tool to determine which way is the best way to follow up our patient. But maybe this will be more sensitive or more specific, and we'll see that. Arshid, maybe you can explain us how currently we're using the system. It's been CE marked since May 2021, and this is how it works at our hospital.
Yes, sure. Thank you, Stéphan. So as soon as we have done the acquisition of the CT scan, there is a link directly to actually to ARVA. It goes at the same time to ARVA that to our PACS. Actually, it goes to a pseudo anonymization center. Then it goes to ARVA, and then it comes back and receiving on our PACS or in our workstation. Meanwhile, the software goes also and try to find the 2 former previous CT scans down in the same center. And if it is the case, and if it finds any of this aortic CT scans, they are sent at the same time to ARVA, and they come back with a clear comparison of the maximum diameter on each segments of the aorta.
Great. And what is interesting is that can you go back one, please? It is. Can you go back to the previous slide, please? I just wanted to say that Est-ce qu'on peut avoir la diapo d'avant, s'il vous plaît? I just wanted to show you that you see the CT scan is either performed in our hospital, or if a patient comes from another hospital with a CT scan performed on any machine, I mean, it is really not connected to a single manufacturer. As soon as you download the CT scan into our packs, it is then automatically uploaded to the aorta system and comes back with the report that Arshid was quoting. So next, please. And this is the report, and you can see it comes in two folders. One is what you can see on the left is every single cut with how the algorithm has selected the aorta wall. So you can scroll through the entire aorta and check that it was an accurate selection of the aorta wall of the aorta. And then on the right side, what you can see is where the system, where the algorithm has measured the maximum aorta at each level. And what is interesting is that you then have the schematic view of the aorta, and in green are the diameters that are supposed to be non-diseased portions of the aorta, and in red, those that are more of a concern, because if there are more than 40 in the aorta or more than 20 in the iliacs, they will turn into red. What is interesting is for each measure, you can see an image of the CT scan cut where the measure was performed. So you can check right away that there is no outlier, that the system performed an accurate measurement. And on the next slide, you will see that for those two red portion of the aorta, so next, please. You will see that it is highlighted, and here it was the infrarenal aorta that measures 76 millimeter, and the right iliac, I think, the right iliac that measures 24. So a specific highlight on those quite large portion of the aorta. This is another example. I just wanted to highlight that the system will automatically depict if there is an endograft that has been implanted. So you can see here, it's the French version. It says endoprothèse détectée. It means that an endograft has been implanted. And you can see in this 3D VR reconstruction of the aorta that you can see where the endograft starts and where it ends. This is a dissection. It's supposed to be a complex case. There are the artifacts due to the endograft, but despite that, you can see here and on the following slide how accurate the algorithm has measured the aorta. Can we move to the next slide, please? And so you can see the various segments of the aorta that are diseased. Here, almost all the aorta, actually, the ascending, the arch, the descending. Next. And finally, I want to quote the interesting follow-up that Arshid was talking about. And if we go to the next slide, this is an EVAR patient. And I think this is what you were quoting, Arshid, if you want to give more details about that.
Yes, sure. Well, here we have 3 exams that, well, they have been, as you said, uploaded, or they were already on the packs, and the ARVA system goes directly to get them and to look for them and just do the comparison of each diameter for each segment, which is very convenient because it is very time consuming where you're doing this in real workflow, and it is so time consuming that you sometimes don't do it, or if you do it just with just the previous one, or just for one segment and not all the segments. The other point is that sometimes you need more anteriority, and well, it is possible also to send your older exam to the ARVA system and have a comparison for bigger anteriority to see if it changes during years or not, which is quite important.
And so we selected here a case where an endograft had a shrinking aneurysm. Obviously, Tara, we will not show one of our cases that failed. So you can see that the aortic diameter is shrinking from 50 to less than 40 here. It's nice to see those curves.
Well, one thing maybe it's important is to say is that we are very focused when we are doing our measurements to where is the aneurysm and the maximal diameter. And with this system, we can have incident of finding other dilation elsewhere, which is not maybe always obvious when we just are going very fast. So the systematic measurement is quite interesting too.
I have one question, Stéphan.
Yes, please, Dominique.
Arshid, can you tell us if there is any recommendation regarding the quality of the CT scan that can be uploaded in terms of number of image, in terms of gating, in terms of all those details? I think are important.
Well, of course, concerning the slices, it's important that the thickness would be less than 1 millimeter, which is the submillimetric slices. It's the case of most of the scans now, but it's true that we already find sometimes 2 millimeters thickness sometimes, which is very thick, far very thick. The other point would be to have an arterial imaging with bolus tracking most of the time, which is also currently down normally. And concerning the gating with the cardiac rhythm, it is important concerning the ascending aorta until the anterior cross maybe arch. For the rest, it is true that it is not very important, but if we want to have optimal and relevant measurement of all the segments of the aorta, it's better to have this gating. The new CT scanners enable us to have a gating on the thoracic part and a non-gated imaging for the abdominal part without very higher exposure that as we had before, because before we had a very high exposure when we used to do that, and now the X-ray exposure is really reasonable, I would say, when you are doing this thoracic gating part and not gating for the abdominal part.
Sarah, you are the only one here that is not using EVAR routinely. I think it's the first time that you had the opportunity to see those reports that are automatically generated by the system. A couple of comments. Do you think that most of the information that you need to follow up your patient is included? Do you like this? You've just disappeared, Sarah. Is it? Did you find it interesting to have the diameters throughout time? I'd like to have your feedback.
I think it's brilliant, and I think the potential here is really powerful. We've always in the past talked about the phenotype of aortic disease being 4-dimensional, in that.
Oh, we lost Tara, or?
I'm back. Some people have aortas that just grow faster, and you guys are going to be able to prove that phenotype and actually kind of report about it. So there's a huge potential for understanding aortic disease better using this tool. I hope you do retrospective work on all the patients you've treated and give us an idea of what those phenotypes are.
That's great. We have quite a significant number of questions from the chat. So Thomas Batronos is asking us what rule defines where is the end of the aorta and where is the beginning of the iliacs. And also there was another question regarding can we edit the various segments. So the answer is no, but we cannot edit the various segments. But what is interesting is that the way those segments are selected for each CT scan is the same way. So meaning that from one scan to the other in the same patient, you will have exactly the same extracted volume segment of the aorta. And I think
maybe I will answer also to this question of Bright Benford. This is one of the issues which was very important for me, that we cannot edit. But once I tried the solution, I saw that, well, most the men, the central line is really reliable, strangely and surprisingly reliable, and you have a very good central line. And most of the time you don't have edits. Sometimes you have, of course, this problem of measurements, and in this case is actually what we do. Of course, we cannot edit, but it goes very fast because you know already where is the problem, and all the segments which are maybe a little bit dilated are flagged, so you go directly there and you do the measurements very fast.
The other thing that I've been really impressed with in dealing with imaging companies that are software based is how quickly they're able to iterate. So I'm sure, even though you may not be able to edit now in the plans.
But if you really want to make sure that your follow-up is accurate, I think not editing is probably something that is not a bad idea, except for the outer wall of the aorta. Sometimes, and as you've seen in our DICE scores, it's actually really a very limited number of patients. Sometimes, obviously, having the opportunity to slightly edit that would be nice. But as you said, everything is going so fast that I'm sure that in the near future we will not need it anymore. Maya Elena Lehner said actually that the AI system would be great to adapt to your studies, Tara, and you already said that you're very much looking forward to that. There was an interesting question regarding if the aortic section is oval, how is the maximum diameter defined in ARVA? Is it the average of two perpendicular diameters? I don't know, Dominique or Arshid, if you want to address that question.
It's a maximal, actually. If the diameter is really oval, it's the maximal, which is considered, of course.
And that's in keeping with the guidelines, because the guidelines say that they're supposed to do it that way.
And remember that it is a perpendicular to the center line of the entire aorta, not the lumen. So it is usually the most accurate way of doing those measurements. Now, how are obvious detected errors corrected then? I think currently when we see in the report that the system has not accurately selected the aorta, then we need to manually go back on the workstation and to check the diameters. But again, this is really, I think, Dominique, this is not something we're seeing anymore. At the beginning of the experience, it was obviously an issue, but this is the beauty with deep learning, is that the system gets better and better every day.
Indeed, but I also one question, Arshid, as an MRI specialist, you always check at the dynamic view of the aorta, and I think maybe you have missing points that are not seen with this program. Maybe something we could add to this program, comparing MRI and CT scan. Maybe.
Well, I think that, well, with CT scans we see a lot of things maybe that we won't see in MR, but it's true that for the MR, for the follow-up, MR would be really suitable because of the X-ray exposure. And if we can develop later the same thing for the MR, that would be really great for some follow-ups. Well, this is another program which is not impossible. We have already discussed with the ARVA team to develop this further. But also concerning what said Stéphan and what you said, Dominique, I think this augmented doctor or augmented radiology of the beginning of ARVA is important, because we have to check always something. And when Tara was saying that we can do maybe all the studies completely automatically, I don't know. I would say that dealing with many different solutions of artificial intelligence and deep learning, it really helps to go very faster. But sometimes they do one error than a 3 years old child wouldn't do. So I think it's always good to have an eye on it, like Dominique said for the patient of this morning. It really helps to go very faster and to be very more complete on our assessment, but to have to check.
Yeah, and so Arshid, on the same topic, Bright Benfer asked, compared to total manual measurements, and in your experience so far, how much manpower goes into reviewing ARVA measurements? I think, Bright, what is important is that you have a file with the entire aorta and the segmentation of the aorta, from the top to the bottom of your CT scan. So you just scroll through the images from top to bottom, and it's, if you are looking at aortas every day, like we all do here, you right away see if the system did a good job. And again, the system gets better and better every day. But so it takes a couple of seconds, and then when you see the report with the various segments and the measure for each segment, because you have the cut that has been used to perform the measurement, you right away see if there's an outlier or if it's very accurate. So in reality, it takes a couple of seconds. In our everyday practice with Dominique, when the CT scan has been performed by Arshid and his team, it's in our hospital. The patient, by the time he comes to our clinic, the ARVA report is already in the packs. And currently, when we upload to ARVA CT scans that have been performed elsewhere, the issue is actually not the ARVA system itself. It depends on our internet connection, how fast we can send the images to ARVA. So we're almost ready to wrap up. Tara, so you would be happy to have access to this solution to your everyday practice and for your research, I understand.
Yeah, I'd love to get my hands on it.
So maybe you need to move to Paris.
I'm finally settled in London.
Just a few words on volume. Do you think, Dominique, Arshid, or Tara, that volume could be something interesting to monitor? And I'm sorry, there's a helicopter just next to us, so I'm going to cut my microphone.
So can I start, because my camera keeps being crazy? I think dissection is going to be where volume finds its best role. So I would really love to see how this system deals with dissection, and if it can tell us true lumen and false lumen volume, because I think that would be really cool to look at.
Arshid, do you want to comment? Do you think volume could be?
Oh yes, yes. I would say volume. I was more thinking about the aneurysm concerning volume, because already with the aneurysm and the evolution of the aneurysm, even with the endoprothesis, it is really interesting to see how it evolves and how the changes of the anatomy of the aneurysm with the endoprothesis during years, and that would be really an interesting point. Of course, false lumen too, but for this we have also some maybe interesting things with the MR-40 flow and to answer also Dominique.
But because we've not had access to volume measurement, because it's so time consuming and such a pain, we only look at maximum diameters. We now have a tool with ARVA that gives us the maximum diameter per segment. But I think if you look only at maximum diameter, sometimes you miss some bad evolution of the sac, because sometimes the increasing part of the sac is not at the level of the max diameter, is higher or lower. Yeah. And I think that if we have volume, we probably will be faster in determining those patients that will require a closer follow-up, or or a secondary procedure.
And maybe one last point, could it be interesting to have more segments than the volume? I mean, to separate the different segments in two or three parts? It's a question for you.
And I guess that there's no limit to what we can do with this system. We will need as physicians to make it evolve and to make, and with the various studies we're going to perform to evaluate perhaps the need to follow up volume, we will then want to be even more specific, and as you said, have require more segments.
I would add one little thing concerning all the aortas we do for other indications. Because you're surgeons, and sometimes this program works also for other patients, like for TAVI patients, for other which have issues. And it is true that we discover new things, and it flags all the segments, which are this anatomic segments which have been defined, and to have this measurements of the different segments, it's really helpful to have incidental findings, sometimes for the ascending aorta, sometimes for the abdominal aorta, and sometimes it doesn't seem so obvious, but as it is flagged, you see, oh, interesting, something is happening there. And this is also one interesting thing which comes out of this software.
Great.
Yes, it's the unknown unknowns that we need to find.
Yes.
I mean, that's a perfect way to wrap up this session. Bright asked any plans in the future to train help aortic surgeons outside our hospital. Yes, Bright, this is a CE-mark product, it's on the market. So I don't know, is England part of CE-mark market? I'm not sure.
Brexit.
Yeah, so we'll make sure that I'll get it on the train on the Eurostar for you. But yes, it's on the market currently, so it's available. This is an ongoing process to make it even better every day, and we would love to have many of you using it. In France, we have a couple of centers in Marseille and in Rennes, in other places that are currently using it. So it's just the beginning of the story. Thank you so much, Tara, Dominique, Arshid, for joining. This was a great webinar. Thank you, Incepto, for organizing that. There were over 50 people connected during the webinar. Have a nice evening, and I'm sure we'll have a next. It's like a never-ending series. We'll have a next webinar in a couple of months with new features to share with everyone. Take care, everyone. Thank you so much.
Bye.
Bye.
Bye-bye.